Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO.
Hi, everyone. Welcome back to Ready, Set, GYO. This episode was originally aired in April of 2024. Since that time, several new phase 3 trials and long-term data have been published. These updates have been incorporated into this episode. We hope you enjoy. This is the third episode in a 4-part series on uterine cancer. Today, we're going to be discussing treatment options for advanced stage and recurrent disease. Sydney, what are our learning objectives for today?
Our learning objectives are to describe the upfront treatment of advanced stage endometrial cancer, recognize the landmark trials which help evolve the treatment schema we have today, delineate the treatment options for recurrent disease, and introduce the available biomarker-directed therapies approved for use in endometrial cancer.
Great. We're going to start today's episode discussing upfront treatment of high-risk and advanced stage endometrial cancer. High-risk endometrial cancer encompasses stage 3 disease or higher, regardless of histology or grade, in addition to serous and clear cell histology, regardless of stage, or grade 3 deeply invasive endometrioid carcinoma, as reviewed in a previous episode. Advanced stage disease is stage 3 to 4. These patients have a relatively poor prognosis if treated with surgery alone. Sydney, how do we decide whether we can or when we should proceed with surgery for these patients?
When patients are suspected to have extrauterine disease or to be at risk for extrauterine disease, it's important to get an understanding of the extent or spread, primarily to determine whether their disease is amenable to complete surgical resection. The NCCN recommends considering a CT chest, abdomen, and pelvis for any patient with high-grade disease, for any patient who has had an incidental finding of endometrial cancer after benign hysterectomy, and for any patient with signs or symptoms concerning for metastatic disease. These findings may include a bulky tumor, vaginal or extrauterine involvement on exam, delayed presentation, or abdominal or pulmonary symptoms. In addition, CA-125, molecular subtyping, and ER testing are recommended.
If I have a patient that I do this workup for and find disease outside of the pelvis, what should my surgical intervention be?
Generally, if patients have disease that is limited to the abdomen or pelvis, surgery is recommended with the goal of optimal cytoreduction. Hysterectomy, BSO, and cytoreduction to no visible disease are the standard. For patients with apparent distant metastatic disease, lymph node sampling and removal is not necessary as it would not change the stage or management of the patient. While we do not have randomized trials in endometrial cancer evaluating the effect of optimal cytoreduction on prognosis in surgical debulking procedures, several observational studies and a meta-analysis have demonstrated improved PFS and OS for patients in whom optimal cytoreduction to no residual disease is achieved. Optimal cytoreduction is more likely to be achieved in patients with stage 3 compared to stage 4 disease. Maya, is there anyone in whom primary surgery may not be the best choice?
Patients with visceral metastases, vaginal, bladder, bowel, or rectal, nodal, or parametrial involvement may or may not be surgically resectable. As always, a patient's medical comorbidities and fitness for surgery should also be top of mind when making these decisions. In a future episode, we'll discuss in detail decision-making surrounding feasibility and safety of surgery for patients with medical comorbidities. We will also discuss surgical resection for ovarian cancer, and these principles generally also apply to endometrial cancer. So for the patients who aren't able to get upfront surgery for any of the above reasons, what other treatment options do we have?
For patients that are poor surgical candidates, options from the NCCN include EBRT with or without brachytherapy and with or without systemic therapy, versus systemic therapy alone, and then reevaluation for surgery is appropriate. These are the same options for patients who are not surgical candidates due to unresectable disease. For those with distant metastases, systemic therapy is generally recommended. Reevaluation for surgical resection and/or radiotherapy can be completed based on the patient's response to primary treatment. There are no randomized trials that have evaluated the use of neoadjuvant chemotherapy in endometrial cancer. However, neoadjuvant therapy for stage 4B disease does appear to confer reduced morbidity at the time of surgery. Decision to perform radiation therapy in patients with widespread metastatic disease not amenable to primary surgery should include consideration of the patient's primary symptoms. Specifically, if heavy bleeding and anemia are present, palliative pelvic radiation can be a temporizing measure, and stereotactic body RT, SBRT, can be considered for isolated distant visceral involvement. After surgical intervention for patients with advanced stage disease, Maya, what are our treatment options, and what are the trials that helped form these recommendations?
For patients with advanced stage disease, systemic therapy is the backbone of adjuvant treatment, with addition of chemoradiation or radiation to be considered in specific circumstances. For those with stage 3 or higher disease, systemic therapy is always recommended. This can also be considered an earlier stage high-risk disease endometrial carcinomas in certain scenarios like serous carcinoma, stage 1B, grade 3 disease, or stage 2 disease. Choice of chemotherapy regimen has been evaluated in several trials. GOG 177 compared doxorubicin or adriamycin and cisplatin, AP, to paclitaxel, doxorubicin, and cisplatin, TAP. The TAP regimen improved survival but had increased toxicity. GOG 184 similarly compared the same regimens in patients that had all previously received surgery and radiation. Except for among patients with gross residual disease, the TAP regimen was not associated with improved recurrence-free survival, and again was shown to have increased toxicity. GOG 209, published in 2020, was a non-inferiority trial which randomized patients with stage 3 to 4 disease or recurrent disease to our current standard of care of carbotaxol with TAP, so that Taxol, adriamycin, and cisplatin regimen, which had previously produced the best outcomes for patients with endometrial cancer. If there is a trial from this section to remember, it's GOG 209, which demonstrated non-inferiority of carbotaxol and found much higher toxicity with the TAP regimen. And this trial established carbotaxol as the new standard of care for advanced and recurrent chemo-naive endometrial cancer. Sydney, how does radiation play into this treatment schema?
Great question. And currently, there isn't a standard recommendation for radiation in advanced endometrial disease. However, you'll see at the end of this discussion how emerging molecular data may change how we think about this. Several trials have investigated whether the addition of radiation to chemotherapy or radiation alone would improve outcomes for patients when compared to systemic therapy alone in advanced stage disease. GOG 122, published in 2006, randomized patients with stage 3 to 4 disease to adjuvant whole abdominal radiation versus cisplatin and doxorubicin. Chemotherapy alone significantly improved both progression-free survival and overall survival when compared to radiation. A possible benefit of chemoradiation when compared to chemotherapy alone had been demonstrated in multiple observational studies, especially for patients with endometrioid histology, high-grade tumors, and positive periaortic nodes, and prospective trials have recently investigated this. In our last episode, we discussed PORTEC-3, published in 2018, which compared adjuvant chemoradiation, meaning cisplatin during weeks 1 and 4 of radiation, followed by 4 cycles of carbotaxol, versus radiation alone in patients with high-risk endometrial cancer after surgical management. In the original publication of PORTEC-3, there was an 11% improvement in failure-free survival, but no improvement in overall survival in the overall cohort. Toxicity and quality of life were worse during the first year after treatment in patients getting combined therapy. Updated 10-year clinical outcomes and post-hoc analysis by molecular classification of PORTEC-3 was published in October 2025, adding to the molecular analysis published by Leon Castillo in 2020. In the all-comers group, there was an improvement in 10-year overall survival from 67.3% in the RT group to 74.4% in the chemo-RT group, with a hazard ratio of 0.73. Similarly, 10 years recurrence-free survival improved from 67.4% to 72.8% with a hazard ratio of 0.74. Molecular analysis was available for 62% of included patients. In those with p53 mutations, despite a worse baseline prognosis, the improvements in overall survival and progression-free survival with chemoradiation were more pronounced. 10-year overall survival improved from 36.6% in the radiation group to 52.7% in the chemoradiation group with a hazard ratio of 0.52. 10-year recurrence-free survival was 37% in the radiation group versus 52.6% in the chemoradiation group with a hazard ratio of 0.42. Patients with stage 3 disease also derived benefit, but the authors point out this is mostly driven by p53 mutated tumors. There also seemed to be a benefit in a small group of patients with NSMP disease, especially with ER negativity, although this is exploratory. Patients with MMR deficient and POLE mutated tumors did not confer benefit from chemoradiation over RT alone. The Leon-Castillo paper also had demonstrated that patients with p53 tumors benefited from the addition of chemo and benefited at all stages of disease. So what do we make of this? Although the 10-year overall survival and recurrence-free survival were improved for all comers, p53 made up about 1/4 of the trial population. Without the p53 abnormal tumors, it's possible that the trial's positive result for all comers would not have been far less impressive and possibly neutral. The strongest evidence for chemoradiation driving clinical benefit compared to radiation alone remains with the p53 mutated subtype.
GOG 258 was then published in 2019. This phase 3 RCT evaluated adjuvant chemoradiotherapy versus chemotherapy alone for patients with stage 3 to 4A or high-risk EC. Patients were randomized to cisplatin at 50 milligrams per meter squared on day 1 and day 29 of radiation, followed by adjuvant carbotaxol times 4 cycles versus carbotaxol alone times 6 cycles. In this study, neither PFS nor OS were improved with combined therapy compared to chemo alone. Patterns of recurrence were different in different arms, with the CRT arm having less vaginal, pelvic, and periaortic recurrences, and the chemotherapy arm experiencing less distant recurrences. Therapy completion rate was higher in the chemotherapy alone arm at 85 versus 75%. Long-term follow-up and overall survival data of this study was published in March 2025. Median overall survival was not reached in either arm. There was no difference in the hazard ratio for death. None of the subgroup factors analyzed, including stage, age, race, gross residual disease, histology, LVSI, BMI, conferred an overall survival benefit from chemo-RT versus chemo alone. How else has chemoradiation been evaluated in advanced stage disease?
I'm glad you asked. The Lunchbox trial was published in December of 2023. This was a phase 3 randomized controlled trial evaluating chemoradiation designed to investigate the impact of sequencing of radiation and chemotherapy in advanced endometrial cancer. They enrolled patients with FIGO 2009 stage 3 to 4A or stage greater than or equal to 1C serous or clear cell endometrial carcinoma. Patients were randomized to either chemoradiation with cisplatin, followed by 4 cycles of standard dosing carboplatin and paclitaxel, which they modeled after the experimental arm in GOG 258, or carboplatin and paclitaxel with 3 cycles, followed by EBRT, followed by an additional 3 cycles of carboplatin and paclitaxel, a sandwich model, hence the name Lunchbox. At their first interim analysis, there were no differences in progression-free survival or overall survival, and the trial was closed early due to a pre-planned futility analysis. So what do we make of these trials? PORTEC 3 asked the question, should we add chemotherapy to radiation? Alternatively, GOG 258 asks, should we add radiation to chemotherapy? PORTEC-3 supports chemoradiation in selected high-risk, especially p53 abnormal and/or serous, stage 3, and select NSMP patients, while GOG 258 confirms that in advanced disease, systemic therapy is king and radiation is for local control only. In addition to chemo and radiation, I've heard that there have recently been big advances in therapeutic options for endometrial cancer, specifically in regard to immunotherapy. Maya, what do you know about that?
Based on the results of the RUBY and NRG GYO18 trials, pembrolizumab and dostarlimab are now considered Category 1 for adjuvant treatment of advanced endometrial cancer for patients meeting certain criteria of disease based on trial inclusion. These are both checkpoint inhibitors which target PD-1. NRG GYO18, published in the New England Journal of Medicine in 2023, was a phase 3 randomized controlled trial which enrolled patients with stage 3 or 4A with measurable disease, stage 4B with or without measurable disease, and any recurrent endometrial cancers. Patients were randomized to carbotaxol plus minus pembrolizumab. They were stratified by MMR status, with roughly 2/3 of patients having MMR proficient disease. 95% of patients had not received prior chemotherapy, and 63% had not received prior radiotherapy, and most had had surgical intervention, almost 90%. Patients with prior therapy were admitted if their treatment-free interval was greater than or equal to 12 months. Notably, all histologic subtypes, with the exception of carcinosarcoma, were included in this trial. The primary outcome was progression-free survival. With 12 months of follow-up in the MMR deficient cohort, the progression-free survival was 74 versus 38% favoring pembrolizumab, with a 70% lower risk of disease progression or death. In the MMR proficient cohort, median PFS was 13 versus 8.7 months, with a 46% lower risk of disease progression or death. Rates of greater than or equal to grade 3 adverse events were higher in the pembrolizumab groups. The overall survival and exploratory analysis manuscript was published in May 2025. The overall survival data was still immature. The hazard ratio for overall survival in the pMMR and dMMR groups were 0.79 and 0.55 respectively, favoring the addition of pembrolizumab, although this did not reach significance. The PFS by RECIST by blind independent central review was 0.64 and 0.45 in the pMMR and dMMR groups, which were both statistically significant. The RUBY trial, also published in the New England Journal in 2023, was a phase 3 clinical trial which enrolled patients with endometrial cancer not amenable to curative therapy. This included patients with stage 3A to 3C measurable disease, stage 3C1 with high-risk histologies regardless of measurable disease, and stage 3C2 to stage 4 disease regardless of measurable disease, as well as recurrent endometrial cancers. Patients were also stratified by MMR status. This trial did include patients with carcinosarcoma. Patients were randomized to carbotaxol plus minus dostarlimab. Primary endpoints were progression-free survival, and they had about 24 months of follow-up at the time of publication, as well as overall survival. The PFS at 24 months in the overall population was 36 compared to 18% favoring dostarlimab. In the MMR deficient population, PFS was 61 versus 16% favoring dostarlimab, and the overall survival was 83 versus 58%. In the MMR proficient population, PFS was 28.4 versus 19% favoring dostarlimab. The overall survival in the pMMR population trended towards improvement, but the confidence interval crossed 1. Grade 3 adverse events were more common in the dostarlimab group. The updated overall survival data was published in August 2024. The data was 51% mature. They found a decreased risk of death in the overall population of 0.69 and 0.32 in the dMMR or MSI high population, both which met statistical significance. The hazard ratio in the pMMR population was 0.79, with a confidence interval crossing 1, which did not meet statistical significance. It's important to note that for both of these trials, patients with stage 3 disease with no measurable disease or completely resected sentinel lymph node positive without enlarged nodes were not included. As such, extrapolation of findings needs to be carefully considered. It's unclear at this time which form of adjuvant treatment is best in this population, especially in patients with pMMR tumors.
Any other notable studies evaluating immunotherapy in this space?
Yes. ATTEND was a phase 3 randomized, double-blinded, placebo-controlled trial evaluating the addition of atezolizumab to standard chemotherapy. 551 patients with advanced or recurrent endometrial cancer or carcinosarcoma with no prior systemic therapy were included. dMMR tumors were equally balanced between the groups with 23% in each. PFS was improved in the overall population, driven by a benefit in patients with dMMR tumors. The PFS was not reached in the chemo plus atezolizumab group versus 6.9 months in the chemo plus placebo group. The overall survival data is immature and inconclusive. There was a numerical improvement by almost 9 months with the addition of atezolizumab from 30 to 39 months, with a hazard ratio of 0.82 and a confidence interval of 0.63 to 1.07. And the p-value was 0.048. This met predetermined criteria for continuing the study, and we await the final results. Neither PFS or OS were improved in patients with pMMR tumors. The most common grade 3 to 4 adverse events were neutropenia and anemia, and were not different between the groups. However, there were more treatment-related serious adverse events in the atezolizumab group at 13% versus 3% with placebo. As we've mentioned, in both NRG GY018 and RUBY, patients were required to have advanced stage disease, either node positive or to have measurable disease, depending on the study criteria. And the use of immunotherapy in earlier stages has been controversial, with many physicians extrapolating the results of these studies to stage 3 disease that's completely resected or to other groups. The Keynote B21 study was published in 2024 in the Annals of Oncology to help us answer the question of whether to use IO in earlier stage tumors. This was a phase 3 double-blinded randomized controlled trial which enrolled patients with endometrial carcinoma or carcinosarcoma with FIGO 2009 stage 1 to 2 with high-grade or p53 mutated disease with myometrial invasion, or stage 3 to 4 disease of any histology or grade. Wholly mutated tumors were excluded. Patients underwent surgery with curative intent and must have had no residual disease postoperatively. All patients got carbotaxol times 6 cycles and were then randomized to pembrolizumab versus placebo. Radiation was allowed. At the time of this first interim analysis, the hazard ratio in the overall population for disease-free survival was 1.02, with the median not reached in either group. The overall survival data was not yet mature. In a pre-planned analysis by subgroup, there was statistically significant benefit with the addition of IO in the dMMR group, with a hazard ratio of 0.31. While in the pMMR group, the hazard ratio for disease-free survival was 1.2. In the paper's forest plot, no other subgroup analysis derived significant benefit from the addition of IO, including in advanced stage disease when not stratified by MMR status. The takeaway from this study was that the addition of IO to standard chemo does not improve disease-free survival in the overall population of patients who have no residual disease after surgery, but those with dMMR disease do seem to derive a benefit. Sydney, any other studies on the horizon for dMMR cancers?
Yes. Keynote C93 is a phase 3 randomized open-label study of first-line pembrolizumab versus platinum doublet chemotherapy in patients with advanced or recurrent endometrial cancer, including carcinosarcoma with no prior systemic therapy. Notably, this study of pembrolizumab does include carcinosarcoma, unlike NRG GY018. Patients will receive either pembrolizumab every 6 weeks for 18 cycles for a total of 2 years versus carbotaxol every 3 weeks for 6 cycles. Recruitment is closed and the study is estimated to complete in 2027. Similarly, Dominica is a randomized open-label phase 3 trial enrolling patients with stage 3 to 4 or first recurrent disease, MMR deficient or MSI high, endometrial cancer comparing carbotaxol versus dostarlimab monotherapy. Patients will be randomized to receive either 4 cycles of dostarlimab every 3 weeks followed by dostarlimab maintenance every 6 weeks up to 2 years, or carbotaxol for 6 cycles. Recruitment is closed at this time, and the study is expected to complete in 2029.
Sydney, has there been anything else published recently that has improved outcomes for patients with pMMR tumors?
As we just discussed, the RUBY and GY018 trials demonstrated efficacy of checkpoint inhibitors in immunotherapy in all comers, including in pMMR subgroups, but had improved response in patients with MMR deficient tumors. As pMMR endometrial cancers make up about 75% of all endometrial cancers, treatment options for this subgroup are sorely needed. The DUO-E trial was a phase 3 randomized controlled trial also published in 2023, which randomized patients to carboplatin and paclitaxel plus minus durvalumab, a PD-L1 inhibitor, and a third arm with carbotaxol durvalumab plus olaparib, a PARP inhibitor. This trial evaluated the hypothesis that adding PARP inhibitor, which addresses homologous recombination deficiency, to checkpoint inhibitors, which address MMR and MSI status, may improve outcomes. It's important to note that there was not an arm in this trial that had PARP inhibitor alone. As such, many have concerns over the applicability of the results, as we can't compare either therapy to PARP inhibitor alone. Patients had stage 3 to 4 endometrial cancer or recurrent endometrial cancer with greater than or equal to 12 months since last treatment and were stratified by MMR status. Primary outcome was progression-free survival. Both durvalumab and durvalumab plus olaparib demonstrated improved PFS at 18 months compared to chemotherapy alone. In the intention to treat population, both the addition of durvalumab alone and durvalumab plus olaparib improved PFS, 10.2 months and 15 months respectively versus 9.6 months in the chemotherapy group. In pre-planned subgroup analyses, patients with MMR proficient tumors conferred significant additional benefit with the addition of olaparib to the durvalumab carboplatin paclitaxel triplet, increasing progression-free survival from 10 months to 15 months. Notably, progression-free survival with carbotaxol alone was 9.7 months. Patients with MMR deficient tumors benefited from the addition of durvalumab to control, with a progression-free survival not reached compared to 7 months in control, but did not further benefit from the addition of olaparib. In patients stratified by PD-L1 status, triplet therapy had the longest progression-free survival of 20 months compared to durvalumab with 11.3 months and chemo alone with 9.5 months. Adverse events and treatment discontinuation were highest in the triplet therapy group.
Any others?
Yes. LEAP-001 was published in March 2025. This was a randomized open-label phase 3 trial evaluating first-line lenvatinib and pembrolizumab versus standard of care carbotaxol in newly diagnosed, advanced, meaning stage 3 to 4, or recurrent endometrial cancer with no prior chemotherapy or disease progression greater than 6 months after neoadjuvant or adjuvant platinum-based chemo. 842 patients were enrolled and randomized 1-to-1. The study did not demonstrate superiority of lenvatinib and pembrolizumab over carbotaxol for the primary endpoints of PFS and OS in the all-comer population or in the pMMR population. Grade 3 and higher adverse events were higher in the lenvatinib pembro group at 79% versus 67%. This study was important for reinforcing chemo with immunotherapy rather than TKI plus immunotherapy as default first-line systemic strategy. Maya, do you know of any other targets we can take advantage of?
In a paper published by Fader et al. In 2018, for advanced stage serous endometrial cancers with greater than or equal to 2 plus HER2 expression on IHC, the addition of trastuzumab to carbotaxol significantly improved both PFS from 9 months to 18 months and overall survival from 24 months versus not reached in the trastuzumab group in the upfront setting. In the recurrent setting, this regimen improved PFS but did not significantly improve overall survival, which we'll discuss later. As a result of this trial, trastuzumab is recommended by the NCCN in combination with carbotaxol as first-line therapy for advanced stage HER2-positive uterine serous carcinoma. It's also recommended for HER2-positive carcinosarcoma, which we'll discuss in our next episode. Additionally, oral selinexor was investigated as maintenance therapy after first-line chemo for advanced or recurrent endometrial cancer, as published in the Phase 3 SIENDO trial in December 2023. Selinexor inhibits exportin 1, resulting in nuclear accumulation of tumor suppressor proteins, including p53. The primary endpoint of progression-free survival was only met in the audited analysis with a hazard ratio of 0.71, and PFS did not meet statistical significance in the intention to treat group in the initial study analysis, as incorrect chemotherapy response stratification data for 3% of patients were identified. Importantly, patients with p53 wild-type endometrial cancer had a median PFS of 13.7 months with selinexor versus 3.7 months with placebo. Selinexor is not yet FDA approved, so at this time it's practically challenging to prescribe. Following the results of this study, EXPORT EC042 is an ongoing Phase 3 randomized placebo-controlled double-blinded study of selinexor maintenance after systemic therapy for participants with p53 wild-type advanced or recurrent endometrial cancer. This study is actively recruiting and study completion is estimated in 2028. That was a lot of material to cover, Sydney. So once we've treated our patients, and if we're able to get our patients into remission, what do we do then?
After primary treatment, if patients have responded and are without evidence of disease, they enter surveillance. This consists of a physical exam every 3 to 6 months for 2 to 3 years and then spaced out, and serial CA-125 if it was previously a tumor marker for them. During this time, patients should get education on signs and symptoms of recurrence. An exam and imaging can be performed at any time if there is concern for recurrence. If our patients recur, or if they progress after primary treatment, what options do we have then?
In the world of advanced endometrial cancer that progress on primary treatment or recur, there are so many options for treatment. The options depend on what the primary disease type was, where the recurrence is, and how long the disease took to recur. The NCCN guidelines are a great place to look this information up because it's a lot to remember. Generally, radiotherapy, surgery, and systemic therapies are all options. Let's talk a little bit about local regional recurrences.
For patients that have recurrences confined to the vagina or pelvis, options include EBRT plus minus brachytherapy if patients haven't received prior radiation, plus minus systemic therapy. If patients got primary radiation at the site of recurrence, surgical exploration or systemic therapy can be considered, as well as brachytherapy. You can also think about palliative EBRT to address symptoms. Since our edition of this episode aired, we now have the results for GOG 238 published in July 2024. This trial enrolled 165 patients from February of 2008 to August of 2020 with pelvic-confined recurrent endometrial cancer. 82% had grade 1 or 2 endometrioid histology, and 86% of recurrences were confined to the vagina. Patients were randomized 1-to-1 to EBRT with 3D radiation or IMRT with a boost by brachytherapy or external beam, with or without concurrent weekly cisplatin. Acute toxicity was higher in the cis-XRT arm versus radiation alone. Progression-free survival was not reached in the radiation arm versus 73 months in the chemoradiation arm and did not reach significance. Given that the addition of radiosensitizing chemotherapy did not improve progression free survival and increase toxicity, radiation alone should be continued for those with low grade vaginal recurrences. Maya, what if patients have disease that recurs distally?
Distally recurrent disease or widely metastatic recurrences need to be assessed for extent and location of disease. If the recurrence is isolated, you can consider surgical resection or targeted radiation. If disease doesn't respond or isn't amenable to local treatment, we need to consider systemic therapy. Similarly, patients that present with widespread recurrences are generally treated with systemic therapy with consideration for targeted SBRT on a case by case basis. How do we choose which systemic therapy to use for recurrent disease?
This decision is highly dependent on the molecular characteristics of the tumor. First-line therapy for recurrent disease includes repeat platinum-based regimens with or without the addition of directed therapy. Both the RUBY and NRG-GY0118 trials, as well as the FADER paper evaluating trastuzumab for serous cancers, included recurrent disease in their studies. As such, patients with a first recurrence may be eligible for the addition of pembrolizumab, dostarlimab, or trastuzumab to standard carbotaxol. Patients with MMR-proficient tumors may be candidates for lenvatinib plus pembrolizumab. The Keynote 775 trial was published in 2022 and evaluated the use of len-pem for patients that had previously received 1 to 2 prior lines of platinum therapy. This study demonstrated an improved progression-free survival of 7.2 versus 3.8 months and overall survival of 18 versus 11 months in patients treated with len-pem compared to investigator's choice chemotherapy. Statistical analysis was planned for the MMR proficient and overall population, and exploratory analysis was presented for the MMR deficient population. In the MMR proficient population, PFS was 6.6 months versus 3.8 months, and overall survival was 17 versus 12 months. Almost 90% of patients on len-pem experienced greater than or equal to grade 3 adverse events, and 67% required a dose reduction. What about other targeted therapies?
As in ovarian cancer, the use of antibody drug conjugates are being investigated in uterine cancer. Several trials have been investigating the use of sacituzumab as part of an ADC. The phase 3 ASCENT-GYN-01 GOG 3104 trial is investigating sacituzumab govitecan in patients with advanced recurrent or progressive endometrial cancer after prior platinum chemo with IO. And the TroFuse 005 GOG 3095 study is evaluating sacituzumab irinotecan in recurrent and progressive endometrial cancer after chemo and IO, and recruitment for this has been completed. We await the results of these trials. If patients have an NTRK fusion mutation, single-agent larotrectinib or entrectinib are targeted therapies available as subsequent therapy. Finally, the use of olaparib plus minus cediranib, which is a VEGF tyrosine kinase inhibitor, were evaluated in the NRG-GY012 trial for recurrent endometrial cancer. This was a negative study that did not meet their primary endpoint of improved PFS, and olaparib alone showed no significant benefit. What about hormonally active tumors?
Patients with ER/PR positive tumors are also candidates for hormonal therapy. No particular drug or dose or schedule has been found to be superior. GOG 122 and 153 demonstrated that tumors that are low grade, well differentiated, and have had a long disease-free interval are most likely to respond. Low-dose therapies may be equivalent or better than high-dose hormones. Fiorica et al. Published a phase 2 trial in 2004 evaluating alternating Megace and tamoxifen in patients without prior hormone or cytotoxic therapy. The regimen was active and in some patients produced a prolonged response. These therapies haven't been compared directly to cytotoxic agents. If patients have disease progression on hormonal agents, a switch to cytotoxic therapy should be considered.
HER2-targeted therapy is also an option for patients with recurrent endometrial cancer that are HER2 positive. Based on the results of the 2018 FADER paper, which showed an improved progression-free survival from 7 to 9.2 months in recurrent uterine serous carcinomas that overexpressed HER2. Trastuzumab, in addition to carbotaxol, is a preferred first-line option for recurrent serous endometrial carcinoma, as well as carcinosarcoma that is HER2 positive. Trastuzumab deruxtecan, which is an antibody-drug conjugate, is another option for patients with HER2 overexpressing endometrial carcinoma regardless of histology, as long as their IHC staining for HER2 is greater than or equal to 2+. The DESTINY trial was an open-label phase 2 study evaluating trastuzumab deruxtecan in patients with HER2-expressing progressive or recurrent solid tumors. Out of 267 total patients, 40 had endometrial cancer, with 60% of those patients having 2+ HER2 IHC and 40% had 3+ expression. The overall response rate among patients with endometrial cancer was 57.5%, the highest of any disease site, with an 84% response rate among patients with 3+ HER2 expression and a 47% response rate in those with 2+ HER2 expression. Of note, cervical and ovarian cancers were also included and had response rates of 50 and 45% respectively. Based on the results of this trial, on April 5th of 2024, the FDA granted accelerated approval to trastuzumab deruxtecan for patients with, quote, unresectable or metastatic HER2 positive IHC 3+ solid tumors who have received prior systemic treatment and have no satisfactory alternative, end quote.
Several studies have evaluated the use of PI3K and mTOR inhibitors in endometrial cancers. mTOR is in the PI3K pathway, and endometrial cancer has high rates of alterations in this pathway, which work to incur resistance to hormonal therapy, lending biologic plausibility to the use of these drugs in combination. GOG 248 evaluated temsirolimus plus minus megase and tamoxifen in advanced and recurrent disease. The combination arm closed early due to excess DVT risk. In the single-agent arm, temsirolimus had an overall response rate of 22%, similar in patients with or without prior chemo. In 2015, a phase 2 trial was published studying the combination of everolimus, an mTOR inhibitor, and letrozole in patients with recurrent endometrial carcinoma. Among the 38 patients enrolled, a clinical benefit rate of 40% and an objective response rate of 32% was observed. GOG 3007, published in 2022, evaluated everolimus with letrozole versus tamoxifen with medroxyprogesterone acetate. In this study, the overall response rate was 22% in the everolimus letrozole arm versus 25% in the megase tamoxifen arm. Patients who were chemo-naive had a markedly higher response rate, 28 months of progression-free survival versus 4 months, with everolimus letrozole compared with tamoxifen megase, which was an interesting finding that is yet to be evaluated in further studies. The everolimus arm had higher toxicity but had a lower thromboembolic rate. Another phase 2 trial targeting this pathway was published in 2022, evaluating the use of letrozole with abemaciclib, a CDK4/6 inhibitor. CDK4/6 is downstream of PI3K and works to drive cell cycle progression. In this study of 30 patients, there was an objective response rate of 30%, with all responses in endometrioid tumors. Responses were seen regardless of grade, prior hormonal therapy, MMR status, and PR status. P53 mutation was a negative predictor of response to this regimen. Speaking of toxicity, a lot of patients have experienced significant toxicity in their primary treatment. Often these patients are hesitant to restart a regimen that might cause additional toxicity or side effects. What can we do to provide patient-centered care for these people?
If patients cannot tolerate multi-agent chemotherapy for any reason, there are a variety of options for single-agent chemotherapy. Choice should be individualized based on prior side effects and current functional status. Paclitaxel is typically the most active single-agent therapy in the recurrent setting, and liposomal doxorubicin can be a good choice for minimizing toxicity. Bevacizumab has also been studied in advanced and recurrent endometrial cancer. Observational data and phase 2 trials have demonstrated improvement in PFS and OS with the addition of bevacizumab to carbotaxol, and it can also be used as a single agent. Ultimately, when choosing therapies for recurrent disease, the most important piece of the decision-making puzzle is meeting your patients where they are, recognizing their past treatment modalities, assessing and respecting their goals of care, and choosing an option that works for them. If patients decide not to pursue further therapy, our next best option is best supportive care and palliative therapy. We'll discuss principles of palliative care, symptom management, and end-of-life care in a future episode.
That's all we have for you today. We hope you learned something on today's episode of Ready, Set, GYO, a podcast for Gyn-Onc fellows. Here are your key takeaways from today's episode. If there are signs of extrauterine disease, surgical cytoreduction is the standard of care if feasible for patients with advanced stage disease, based on observational and retrospective data demonstrating improvements in overall survival with optimally cytoreduced disease.
For advanced stage disease after surgical intervention, or in patients in whom surgery is not feasible, systemic therapy is considered the foundation of adjuvant therapy. Addition of immunotherapy in the form of pembrolizumab, dostarlimab, and/or trastuzumab is a recent practice change. Depending on risk of recurrence, radiotherapy can also be considered.
There have been many trials to determine the optimal form of adjuvant treatment. Each GOG trial was foundational to determine the next step of inquiry and ultimately helped us arrive at the systemic treatment recommended today: carboplatin plus paclitaxel plus minus targeted therapy.
The location of recurrence and prior therapies a patient has received contributes significantly to choice of recurrence therapy. Generally, radiotherapy, surgery, and systemic therapy are all options. Radiotherapy and surgery are most often used in local regional recurrence. Systemic therapy, including choice of cytotoxic chemotherapy, hormonal therapy, and/or biomarker-directed therapy, is more often used for unresectable metastatic disease.
Biomarker-directed therapies represent a changing landscape in treatment of endometrial cancer, both in the upfront and recurrent settings. Knowledge of their indications, dosing, and risk factors are important, and these details will be further explored in a future episode.
This has been another episode of Ready, Set, GYO, your source for all things Gyn-Onc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Taylor Oriana, faculty at the Medical University of South Carolina, who reviewed the content of this episode today for accuracy and completeness. Sydney and Maya, signing off.